Well, good morning, everybody, or good afternoon, or good evening, depending on where you are in the world. My name is Mike Cohen. I'm a pharmacist with the Institute for Safe Medication Practices, and I also am the chairperson for the International Medication Safety Network. And I'd like to thank all of you for joining us this morning. We have presentations on 3 different topics that are related to medication error prevention. And the title, of course, as you can see on the title slide, Recurring Serious Medication Errors That We Can Do Something About. So I wanted to talk to you and welcome you. I am joined by a couple of colleagues here at ISMP that are actually fellows with the Institute for Safe Medication Practices. They're international fellows. The first person is Dr. Marissa Anderson. She is with us for a 1-year program, along with Jill Pallier, Dr. Jill Pallier, also one of our international fellows, and each of us will take a different topic. I would really like to thank the Uppsala Monitoring Center, UMC, and especially Alan Zakaria for working with us to make this presentation possible. We've met many times by internet, and also met one another last year at the IMSN annual meeting, which was held in Rabat, Morocco. We had a good turnout there. Unfortunately, this year, because of COVID-19 affecting the world, our meetings are being held virtually by Zoom or Microsoft Teams or some other system. But it's good to get together, and we've been looking forward to doing this presentation on 3 very significant types of medication errors. I'll be serving as your moderator, and I'll also be speaking. And they actually put me first, so you'll hear from me first on my topic. There is going to be time for question and answers at the end. I'm figuring each of us will talk for 10 to 15 minutes or so, give or take. And all you need to do is just add any questions that you have to the chat or the Q&A. We'll be monitoring both of those for any questions that you have, and we'll try to get to all of them. There is a set of slides, the slides that we are using right now, that is being made available to you. And you should be able to see the link to get those slides in the Zoom chat area. I'd also like to thank Jordan Rufo, who is coordinating this program on our end here at the Institute for Safe Medication Practices, ISMP. So I want to go over first the objectives. May I have the next slide, Jordan? We're really going to be talking about 3 different issues, as I mentioned. One of them has to do with 2-component vaccines. And we're going to be talking about some high-level strategies to reduce the risk for these types of errors. And I will let the fellows describe some of the problems that we've had with 2-component vaccines, but very quickly, we're talking about vaccines that require a diluent or vaccines to mix, for example, a lyophilized powder, or vaccines that have 2 components, both of which are antigens, but have to be mixed. So we're giving only 1 injection to the patient. And unfortunately, we've had some very serious medication errors, which we will be discussing. And then also, and this is probably one that you have heard about, but we want to tell you about some actions that have been taken here in the United States to prevent this from happening, and I think you'll find that interesting. We want to describe high-level strategies to prevent fatal wrong root errors with the cancer drug Vincristine and other vinca alkaloids. So we'll be talking about that very shortly. And then I'm going to start off with identifying recommendations for safety enhancements for the use of the antifibrinolytic drug Tranexamic Acid. Unfortunately, we have had a number, scores of reports of accidental injection of tranexamic acid into spinal fluid, an intrathecal injection or an epidural injection where it was mixed up with bupivacaine for regional anesthesia. These drugs are often in the same location in the operating room environment and in obstetrical areas. So they're used to stop bleeding, and we'll describe that next. May I have the next slide? So first, let's talk about the fatal errors with tranexamic acid when it is given by the wrong route. Next slide, please. First of all, it is an antifibrinolytic drug. It's in that class. Another one is aminocroproic acid. We don't really use that too much now because tranexamic acid is available. And as an antifibrinolytic, how it works is it prevents the conversion of plasminogen to plasmin. And plasmin is what breaks down the fibrin clots. So this prevents that breakdown and therefore can be used to treat cases of bleeding. And it is given by various routes. We're most concerned here, of course, with an intrathecal or intraspinal injection or epidural or any type of neuraxial injection. We're most concerned about the injectable tranexamic acid. But there is also an oral drug. In fact, we don't have it here yet, but I understand in some parts of the world there is an oral product that is available over the counter for bleeding during menses. It is also used intranasally, and it's used topically in other ways. For example, applied to bleeding tissues, oozing blood. It is also applied, for example, during knee surgery. If you do a search on the internet, you will find that this drug is used in a number of different ways. It is also available as a liquid. And so we're talking about the injectable though, again. When it is given intraspinally by accident, instead of a local anesthetic, and what happens here is, in many cases, we want to administer regional anesthesia. And we may use that as a spinal anesthesia or epidural anesthesia, for example, during childbirth. And unfortunately, and you'll see I have some pictures here of these products, the injectable products, because of a look-alike appearance. We've had, as I said, scores of actual mix-ups around the world. And we've had some here very recently in the United States that caused us to put out a national alert here. And that's one of the reasons we wanted to bring this to the attention of the world's pharmacovigilance centers. Many of you are part of a regulatory authority or obviously have links to regulatory authorities. And so we wanted to show you some photographs and talk about some ways to prevent this error. But it is, tranexamic acid is a potent neurotoxin. And basically what happens almost immediately, it happens very quickly after accidental injection into the spinal fluid, instead of a drug like bupivacaine, the local anesthetic, or ropivacaine, another local anesthetic. If this is mixed up and enters the spinal fluid in error, patients frequently will experience a seizure. So it is a neurotoxin. And another thing that happens is there's a release of epinephrine, and the heart rate increases, and there are a number of cases of ventricular fibrillation and cardiac arrest, which is cardiac arrest essentially. And so it turns out that in one of the papers that was published, the claim was about 50% of these cases in a meta-analysis led to a mortality. And almost all of these are harmful in some way. Many patients have survived, but temporarily may have been paralyzed, for example. Paraplegia is not unusual either. I have one of the references here And I believe I have a photograph of it as well. Can I have the next slide so we can show you what we're talking about? Now, this drug around the world is available in either drug vials here in the United States. We do not use a lot of glass ampoules. The labels are very hard to read. And it is actually the subject of some of the work of the International Medication Safety Network. We recently wrote a white paper about the glass ampoules and how hard they are to read the label because there's generally no background. And there are many mix-ups that happen on nursing units when the nurses don't even realize they picked up the wrong ampoule, may have been thrown into the wrong floor stock, for example. But we have presented information in a white paper to the International Council on Harmonization, asking that they interact with the world's pharmaceutical companies and the regulators to, at least if we're going to use glass ampoules, we need a ceramic or paper background on the label. Because when you hold many of these up that have dark print, and I'm looking at the vials here, I'm sorry for confusing you, I'm talking about the glass ampoules. I'll show you a picture of that in a minute too. When you hold them up against a dark background, it's very difficult to read the label. But in the US, we use these vials. And you can see the two drugs have similar cap colors. So on the left is tranexamic acid with a blue cap, and on the right is ropivacaine with a blue cap, the local anesthetic. And sometimes these are stored in drawers, in a drug cart, for example, a drug storage cart of some type. We use a lot of automated dispensing cabinets here in the United States, and if they're very low and below eye level and standing up, and all you see is the blue cap, we have seen these cases now where they picked up the wrong drug and never really read the label. We do use barcode scanning, but it's not available in all areas of all hospitals. So, you know, the order may not even be entered so that you could match it with the barcode. And this is how some of these errors have happened. Next slide. So there are several articles, ran across 4 or 5. This is a very recent one. I looked at 21 cases, and life-threatening neurological or cardiac complications requiring resuscitation or transfer to intensive care occurred in 20 patients, and 10 patients died. So there's your 50% in this one study. So in the same journal, by the way, next slide, there was an editorial. Spinal tranexamic acid, a new killer in town. And one of them I already talked about was making sure that we have backgrounds on the ampoule. I'm talking a paper background, or have the companies put a ceramic background so the labels can be easily read. You can see how similar the ones are on the top. The ones on the bottom have paper. They're a little bit easier to read. They can be mixed up as well. This is a publication of our Anesthesia Patient Safety Foundation in the United States. Next slide. Most of these glass ampoules are foreign. This is a photo of the National Alert Network that we sent out to all hospitals, ambulatory surgical centers, many other organizations. It went out nationwide. It gave a number of recommendations for our prevention. Next slide, please. Our recommendations, I've given a couple of these about separating them from and their storage locations, the 2 different drugs, not storing them anywhere near one another. Never allowing any drug vial to stand up when it's below eye level. They always should lie flat with the labels facing forward. And then also minimizing these look-alike caps. We tell facilities to purchase one product from a different manufacturer if it has a blue cap. There are other manufacturers. These are generic drugs. And that is one way to prevent this mix-up, to make them look different. We also think that organizations can place auxiliary labels that say contains tranexamic acid over the vial cap. That would be another way to prevent this. we're always looking at what we could do to prevent the error, not, blame the person that's made the error. We want to know what allowed this error to happen. And in these cases, it's almost always look-alike. Barcode scanning. Unfortunately, in the United States, in many ORs, many obstetrical areas, delivery rooms, we do not use barcoding. So if these drugs are stored there, it's generally not available as a mechanism to prevent errors. Our barcoding is used very, very widely in medical surgical units, in ICUs, intensive care units, et cetera, but unfortunately not in the area where a lot of these errors have taken place. Sometimes in orthopedics as well. Next slide. And, we have a new standard, ISO standard, International Standards Organization, for connectors for spinal use. It's called NRFit, and it has a different fitting than a Luer. Right now, most locations are using a Luer connection for spinal injections. Already in the United States, we have begun to use NRFit, which is a kit that has a special connector and syringes for use with bupivacaine, ropivacaine, and local anesthetics that are given through the neuroaxial route, whether it be spinal or epidural. So that's a way to prevent this. And another is getting pharmacy to prepare these the drug in a premixed container, or in the United States, we have a premixed tranexamic acid that's already in fluid. So it's not in a vial. And that can be used for bleeding when it's given. So that would avoid the ampule or the vial altogether. We use a lot of premixed products in the United States and pre-filled syringes as well. They're a little bit more expensive, but certainly worthwhile. And that was also included in the white paper contents that we sent to the International Council on Harmonization. We'd really like to see an increase worldwide of pre-filled syringes from manufacturers and pre-mixed containers, so that this doesn't fall on the nurses and doctors to mix these. Otherwise, where pharmacy can prepare it, that's what's best. And then finally on this slide, local anesthetics may be available at some location in these pre-mixed containers or prepared by pharmacy for use in regional anesthesia specifically. Next slide. Okay, I am going to turn this over now to Dr. Anderson, and she's going to be talking about IV Vincristine prepared in a mini bag, which is a WHO-supported presentation, to prevent fatal wrong route errors. And we'll tell you about something that's happened here in the United States. Dr. Anderson?
Thank you, Mike, and good morning to everyone else. If I can get the next slide, please. So I'm going to talk about how we can prevent Bencristine errors. So to start off, I just want to talk about what the error is when IV Bencristine is inadvertently administered by the intrathecal route. So when zinc alkaloids are given via the intrathecal route, there is a fatal neurological demise that does lead to usually a patient's death. And of all zinc alkaloids, Bencristine is particularly problematic and the most frequently reported for accidental intrathecal administration. Because Bencristine is most often used in combination with drugs that are intended to be used intrathecally, it's easily available to be administered by the intrathecal route. When this occurs, it causes a radiating destruction of the nervous system, starting with an ascending myeloencephalopathy, causing a persistent vegetative state and quadriplegia, which then leads to patient death. This does not occur quickly, and it can develop over days to months, which leads to patient suffering throughout the entire process. If we can go to the next slide. So I'll start by sharing one of the first cases. This occurred several decades ago now in 1989 in Harrisburg, Pennsylvania, here in the United States. This was a 3-year-old child who died after Bencristine was accidentally administered intrathecally. This child was to receive 2 drugs, One was to be administered into the spinal canal, and the other, Vincristine, was to be administered intravenously. The physician who was administering the medication simply just picked up the wrong drug at the wrong time, and it was a swap of syringes, and administered the Vincristine intrathecally, and it led to a fatal event. Next slide. Here we have another report of a Vincristine error, which details the excruciating effects. This explains how the patient's eventual demise was not for 10 weeks after the erroneous administration of Vincristine. This highlights how prolonged the adverse effects of this error can be, and how much suffering is truly associated with these errors, which is why we really need to take all efforts in order to prevent them. Next slide. Here we have one of the most recent reports in 2019. 3 children died as a result of the incorrect administration of Bencristine at the Georgetown Public Hospital in Guyana. So this just proves that this error does not know age or geography. It's happened in the United States, it's happened worldwide to children and adults, which is why I want to share it with everybody today. Next slide. So we have over 140 confirmed reports, and of these, there have been no accidental administrations of vinca alkaloids by the intrathecal route when it's dispensed in a mini bag or flexible container. They've all been prepared in a syringe, and you can see listed on the slide just all of the different countries where these reports have come from. So if you go to the next slide, you can see a picture of what I'm talking about. So on one side, you'll see the drug prepared in a syringe, which you can easily swap with another medication prepared in the syringe, which is intended to be administered intrathecally, whereas the drug on the other side, prepared in a larger mini bag, is very physically different than a drug prepared in a syringe and has a much larger volume, which creates a much clearer distinction to the administering physician that the Vincristine should not be administered by the intrathecal route. So when you can see on the bag of Vincristine, it does have the label for do not administer by the IV route, fatal if given by other routes. So this labeling would be placed on the syringe, but we can see that these warnings are not enough, and we need physical barriers such as the mini bag in order to prevent these errors. So if we go on to the next slide, we can see that this recommendation is backed by extensive research that proves that Vincristine at a range of doses is stable to be diluted and put in a mini bag, and the physical and chemical stability is not affected. And there was also additional studies to show that the rates of extravasation between the syringe administration and the mini bag administration of Vincristine showed no significant difference. So we can consider this practice to be just as safe in that sense. So on the next slide, we can go over a recommendation to dispense Vincristine and all vinca alkaloids in a mini bag of a compatible solution and never in a syringe. And ISMP has been strongly advocating this practice since 2001. This has been backed by the World Health Organization to promote the dilution of vinca alkaloids in mini bags, as well as the Joint Commission, the American Society of Clinical Oncology, the Oncology Nursing Society, the National Comprehensive Cancer Network, and the World Health Organization. On the next slide, you'll see that the National Comprehensive Cancer Network, which is a not-for-profit alliance of leading cancer centers here in the United States, which is devoted to patient care, research, and education, started this campaign called Just Bag It, which included all 27 of NCCN's member institutions who committed to only ever preparing Vincristine in the mini bag or flexible container and never in a syringe, which really got this practice to be more popular here within the United States. So on the next slide, I have a couple additional safety strategies to be implemented to prevent this error. You can prohibit intravenous Vincristine in areas where intrathecal medications are administered and stored. and you can confirm that any prescribed intrathecal medications have been administered before dispensing IV vincristine. So making sure that the intrathecal hydrocortisone has already been given before vincristine ever enters the room, just to ensure that there is far less of a chance of that syringe swap occurring, or in this case, the mini bag not even being in the room. On the next slide, you'll see the ISMP targeted medication safety best practices for hospital. These best practice medications are put out by the Institute for Safe Medication Practices based on the error reports that we receive through the ISMP National Medication Error Reporting Program, and they've been reviewed by an expert advisory panel. These were developed to identify, inspire, and mobilize widespread national adoption of consensus-based best practices for specific medication safety issues that continue to cause fatal and harmful errors in patients. The best practice to dispense vincristine and vinca alkaloids in a mini bag of compatible solution and not a syringe was first introduced to our targeted medication safety best practices in the 2014-2015 edition. So we have been supporting this issue and our best practices now for over 5 years. Our next slide shows that this is also a global targeted medication safety best practice through the International Medication Safety Network. The IMSN Global Targeted Medication Safety Best Practices inspire to mobilize widespread international adoption of these consensus-based best practices for medication safety issues that lead to harmful and deadly medication errors. Jill, my co-fellow, is going to be talking about another one of the global targeted medication safety best practices after me, so you'll hear some more about these. And the primary goal of these targeted medication safety best practices is to redesign the medication management process to make it harder for these errors to ever reach the patient in the first place. So again, this is advocating that vinca alkaloids will always be prepared and administered in a mini bag and never in a syringe. The next slide shows that this is ISMP's hierarchy of the effectiveness of risk reduction strategies. So what the least effective strategies are going to be are things that kind of just tell people what to do, like that warning label I showed you on the mini bag of vincristine, which just showed, you know, do not give this by any other route except for IV, which is easy to overlook when it's something that you see regularly and it relies on a human to process that and allows for human error. And then the further you go up on this hierarchy, we have forcing functions, barriers, and fail-safe, which is a system strategy which does not allow human error into the process. So in this case, having more volume and having a distinct physical difference would not allow for this medication to be administered by the intrathecal route, and thus creates a more effective strategy to prevent this error from ever occurring. On the next slide, I show you one of our ISMP medication safety alerts. So in our newsletter, we called on the FDA to change the labeling for vinca alkaloids, to remove the labeling for the preparation of vinca alkaloids in a syringe to prevent this error from occurring. So although it did include in the package labeling that this medication was fatal if administered via the intrathecal route, it did still have preparation in a syringe in that labeling. Next slide. So in June 2020, we published another newsletter article that alerted everyone that the labeling was changed. Pfizer revised the prescribing information for vincristine sulfate injection at the request of the FDA. Per request of ISMP, the National Comprehensive Cancer Network, and the Joint Commission, FDA recommended the revision of the package labeling, which now states to reduce the potential for fatal medication errors due to the incorrect route of administration, vincristine sulfate injection should be diluted in a flexible plastic container and prominently labeled as indicated for intravenous use only, fatal if given by other routes. Administration of the drug via syringe is now completely removed from the package insert. And next slide. So in summary, there have been no reported administration errors when Bencristine is diluted and prepared in a flexible container. Implementing the use of mini bags for preparation and administration of Bencristine implements one of our high leverage system-based error reduction strategies. When prepared, the drug should always be labeled for intravenous use only, fatal if given by other routes. And we want to keep IV Bencristine dispensing and administration physically separate from the drugs given by the intrathecal route. So with that, I will pass it over to my co-fellow, Jill Pallier, who will talk about the safety of two-component vaccines.
Hello, my name is Jill, and I'm going to be talking about the safety considerations for minimizing vaccine-related errors with two-component vaccines. We can go to the next slide, thanks. First, I just wanted to let everyone know about the ISMP Vaccine Error Reporting Program, which we call VERP, that we use here in the US. ISMP has partnered with the California Department of Public Health to develop this web-based vaccine error surveillance tool. So we have an online portal, and all vaccine errors in the US are self-reported on this portal, and then we can collect information such as the type and description of the error, the implicated vaccine, and provider information. We've received over 3,000 error reports on this portal. So a lot of my examples and cases that I'll be sharing in this presentation, we've received through this online portal. And I know many of you are located in countries other than the United States, but I wanted to let you know that if your country has some sort of a vaccine error reporting program, we'd advise you to look into that and report to that portal if there's any vaccine errors in your country, just so that you can learn from those events and work together to prevent those. Next slide, please. So to define two-component vaccines, this basically means that the vaccine comes in two separate components that need to be mixed before the vaccine is ready to be administered to the patient. So typically there will be two vials like you can see here in the picture. The first is going to be an active ingredient, usually a lyophilized or freeze-dried powder. And the second is going to be a vaccine-specific diluent, which is the liquid used to reconstitute or mix that powder. Or it could be a liquid antigen or adjuvant, which is another like active ingredient, but it's liquid used to mix with that powder. So you need both of these components for the vaccine to work. We can go to the next slide. Here are a few examples of two-component vaccines. Many of these you may be familiar with. So basically, as these are stored, there's going to be two separate components that need to be mixed together before it's ready to be administered. Next slide, please. So this chart shows what can go right and what can go wrong with these two-component vaccines. So I'll kind of go through the chart. The top row that you can see is where you use the correct active ingredient or powder and the correct diluent. You mix those together and your vaccine is ready to be given. No error has occurred here. So this is how you're supposed to mix it. The second row is when you use the incorrect powder and the correct diluent. This is considered an error because you haven't even given the active ingredient or the correct vaccine, powder. So it may not be effective, or you may be giving an incorrect drug or product to the patient instead. The next row is where you give the correct diluent, but maybe you forget completely to mix it with that powder. So again, the patient doesn't even get the active ingredient, and it's not going to be an effective vaccine. The next row, you can see you've got the correct powder, an active ingredient, but the incorrect diluent. So here you potentially pick up a different type of liquid medication and use that to dilute the powder. And that other medication could be dangerous or harmful to the patient. So you definitely don't want to be mixing like this. And then the final row, you just give an incorrect diluent and no active ingredient. So all of those four bottom rows are considered errors that could happen with two-component vaccines. You can go to the next slide. And here are some of the headlines to show some vaccine errors that have been in the news. And these can become a really big deal and gain a lot of media coverage. When vaccine errors happen, some groups who are against the use of vaccines can use these headlines and media to contribute to public concern and mistrust around vaccine use. And so when the public is concerned about vaccine safety, they might stop getting vaccinated and stop vaccinating their children. And this can lead to decreased vaccination rates in general and can cause outbreaks and other problems. So we can go to the next slide. So here's an example I wanted to share of a 2-component vaccine error in Samoa from a couple of years ago. So a medication error occurred with the measles, mumps, and rubella vaccine that was incorrectly reconstituted with the wrong diluent, something called atracurium, which is a paralyzing agent. So what atracurium does is it basically paralyzes every muscle in your body. So you can't breathe, you can't talk or yell or move or anything. And then unfortunately, this product was administered to 2 children accidentally, and both children sadly died from this error. So obviously that's very sad, and the public heard about this and they became very concerned that vaccines were not safe based on this incident. And in Samoa and a number of other countries in the Pacific Islands, there were low vaccination rates because people were afraid of the vaccine. So only about 31% of people were even getting vaccinated, and so they weren't being protected from these infections. That resulted in a measles outbreak with over 200,000 infections and 85 deaths from measles because they were not vaccinated. And a lot of those deaths were unfortunately children under the age of 5 as well. So on the right here, you can see we actually partnered with the Uppsala Monitoring Center to write a report about this specific case. You can read more about the details here later if you wanted. You can go to the next slide. So another type of error that can occur with 2-component vaccines is described here with the Menveo or meningococcal vaccine. And in this scenario, you've got the 2 vials that must be combined before administration for the patient to get the full immune response. So there were over 390 reports of administering only one of these 2 components to a total of 407 recipients. So to break that down, 269 patients received only the liquid component, and 138 patients received only the lyophilized or powdered component that had been mixed with a different diluent. So none of these patients were fully vaccinated because you need both components for the medication to work, for the vaccine to work. And so all of those patients ended up needing to get revaccinated since they weren't vaccinated correctly the first time. So going to the next slide, just to look at that Menveo label, you can see on the top, this is the old label and all the text is in pink. And there is a little note on there not to be used alone, but it's kind of hidden with all the other words on the label. So the manufacturer of this specific vaccine actually updated their label on the bottom using color and the black and the red to kind of emphasize and to make that alert stand out, not to be used alone. And that's much more visible now on this label. And since they've updated this, there have been much fewer cases where people would only administer one of the 2 components. So we can go to the next slide. Another packaging issue I wanted to show you is with the rotavirus vaccine, specifically this product called Rotarix. This is an oral vaccine product, and you can see in the picture on the top, there's an oral syringe, and you will actually use that transfer device to connect to the vial that contains the powder. And you push in the oral liquid to reconstitute the powder. You draw it back up into the oral syringe, and then you would give it to the patient by mouth. So that's how this should be given. However, on the bottom picture, you can see that when you look at this oral syringe, it kind of looks like any other type of syringe. For example, other vaccines that are given by IM or subcutaneous route. So some people have confused this product and thinking that once they reconstitute it, they need to give it by injection. So the oral syringe doesn't have a luer connector, and you can't even attach a needle to this syringe. However, people still might think like it looks like it should be given by an injection. So they could actually get a different needle and syringe, draw up the liquid, and then inject it that way. So if we look at the next slide, here's an improved packaging for the same type of vaccine. And in this case, it's in this squeeze applicator, which is used to reconstitute the product. And this doesn't look anything like a needle and syringe, and hopefully no one would confuse this for something that you would give via injection. So this is, we think, a better packaging design, just to really show that it should be given by mouth rather than by injection. Next slide, please. So as Marissa mentioned before, the International Medication Safety Network has a number of global medication safety best practices that we definitely recommend as well. And they have one specific to preventing errors with two-component vaccines. And they're recommending specifically high leverage strategies to reduce the risk of errors with these types of vaccines. So if we go to the next slide, I'll just mention a few of these briefly. So for any facility that is storing or using vaccines, they recommend circling or highlighting any critical information on those vaccines or using flag type reminders, for example, not to be used alone or what diluent should be used and things like that. Also making sure that any dangerous drugs such as paralyzing agents are not stored in proximity with those vaccines. So like we saw in the example with the atracurium, that should never be stored close to vaccines because we don't want anyone to ever try to reconstitute a vaccine with something as dangerous as that. Next, they recommend using barcode scanning systems, if possible, to ensure that you're using the correct components. So if you have barcode scanning systems, you'd want to make sure to scan both components during the vaccine preparation to make sure that you have the two correct components that you're mixing together. And next, they recommend to incorporate the patient or family member in the checking process with vaccines. So this is a great practice for all types of vaccines, and just making sure that you're showing the patient or the family member the vial or the syringe that you're using and the components, making sure that it's the product that they're expecting and anticipating as far as what vaccination, and you can kind of walk them through the process to make sure that you're preparing it correctly and giving it correctly to them. So there are also a few recommendations specific for manufacturers, technology companies, and regulatory organizations. So for example, they're recommending that manufacturers can provide both components in a single container or package them in a way that is very clear that these should be used together and provides a fail-safe as far as the preparation. Also making sure that all labels provide clear instructions for how to mix it. And then finally, making sure there's a process to keep both vaccine components together, which I will give a few more examples on the next slides. So some vaccines may actually come with these little connectors that you can use to keep the two components together. If not, you can just use a regular rubber band just to make sure the two vials are together, and hopefully will be obvious that they should be used. Mix those two together and not using the incorrect diluent. Next slide, please. Here's an example of a two-chamber vial used for medication with diluent. And we haven't seen a vaccine product that is packaged this way just yet, but the package design would be, a great design for a two-component vaccine, because you can see here on the bottom of the vial, you have the lyophilized powder, and on the top of the vial, you have the liquid diluent. And when you kind of break that connector, the liquid can go into the powder, mix it up, and then you can just draw the prepared vaccine right out of the vial. There's no risk for diluting it with the wrong diluent. Next slide, please. So here's another package design. This is a two-chamber syringe prototype. You can see in the picture on the top, the yellow would represent the lyophilized powder or active ingredient, and the blue would represent the diluent. When you push the plunger, the blue liquid will pass through a bypass channel into the powder. You can kind of shake it gently to reconstitute that, and then you have the green product, which is your vaccine that's ready to be administered. And you can just continue to push the plunger and administer directly from that device. Next slide, please. So I don't think any of these 2-chamber syringes are available in the US, but I do understand that this product by a team is available in Europe. And this uses that 2-chamber syringe product design. And you can see here just the instructions as far as how to prepare it. But that would be a great option for 2-component vaccines in the future. Next slide, please. So that's everything that I have. And at this time, we can open it up for any questions for any of our 3 presentations. Thank you.
Okay, thank you very much, Drs. Anderson and Palliet. I just want to comment that, you know, as you can see, these topics that we just discussed, these errors are preventable. I know you process a lot of adverse drug reaction reports and side effect reports and so on, and, you know, very, very difficult to control. In this case with medication errors, vaccine errors, they are in fact preventable. And, you know, I know that that is a charge for the pharmacovigilance centers to address medication errors as well. We have the International Medication Safety Network, which is becoming a growing organization for pharmacovigilance centers, regulatory authorities, those of us like ISMP in Canada, Spain, Brazil, like the NHS in England, and Prescrire in France, and many others around the world also are members of the organization. And we also have people from industry that are associate members, and we meet each year. And it's becoming a growing forum to work together to discuss items like this, which really can be, you know, not very easily in some cases, I will admit, but, you know, with some work, especially with regulated with the regulated products and with working with the regulators, these can be controlled or eliminated. So I hope that, you know, you will go over this material and that you, you know, that you learn from the material this morning. You know, I hope that we can do this again someday soon. I did want to comment, and I don't see any active questions, but I did see a comment rather posted on the chat from Hala from Iraq about a problem that they had, which was a mix-up between hepatitis B vaccine and insulin. And it actually led to 4 deaths. I don't know that it happened in Iraq, but perhaps it did. That's the kind of thing that, you know, we have seen around the world, not with hepatitis B vaccine, but with influenza vaccine. We have 8 different links on our another program that we do on medication errors with vaccines in general, where insulin has been mixed up with influenza vaccine. And that has happened in Holland, it's happened in Brazil, it's happened in the United States and other countries as well. And it happens because, just like the hepatitis B vaccine that Hala is commenting on, being stored in the same refrigerator as insulin, that's how these vaccine errors happen with mix-ups between influenza vaccine and insulin. We've also had a purified protein derivative of tuberculin mixed up with vaccines. So all of these get reported, and a lot of it has to do with the storage conditions, look-alike vials, and so on. And we can do something about it. With the hepatitis B vaccine, that is given when, you know, the baby is still in the hospital. When they're born, they get the first dose, and then subsequent doses in the, you know, in a pediatrician's office. If this is stored in the same refrigerator as insulin or other drugs, we've had mix-ups with methergine, methyl organobine in hepatitis B. where the mother got the hepatitis B and the baby got the methergine, which of course is a uterine stimulant. These are tragic events that just don't need to happen. And we get these reports at ISMP. We work very closely in the United States with our regulator, the Food and Drug Administration, and our other members in Canada with Health Canada, our ISMP Canada with Health Canada, in Spain with the Ministry of Health and others, in Anvisa and ISMP in Brazil, and I'm sure NHS folks work with MHRA in England, and I could go on and on. We need to see more of this, and we need to take action. And, you know, I think many of you are in a position to pick up on this information, and, you know, over time, we can have an effect on reducing these medication errors that are sudden, surprising, and no one ever expects would happen, and yet they can be fatal. They can cause severe harm, loss of body functions, neurological damage, et cetera, that just doesn't have to be. So I hope to continue with UMC, ISMP, IMSN. We have other speakers from our membership in IMSN to talk about errors in their countries. We love the idea of having this occasional forum to get together with the world's PV centers that have such a responsibility, not only with ADRs, but now with medication error prevention as well. We hope to help that along. I'm going to check one more time to see if we have any questions, but we are right up against the 10 o'clock hour. I do also want to mention that one of our colleagues here in the United States, Dr. Andrew Seeger from Boston, also entered a comment on the chat function about Vincristine being available. That's another vinca alkaloid that wasn't mentioned, but is available internationally, but not in the United States. So yeah, and Hala is telling us now that yes, that incident with the insulin and hepatitis B in the 4 babies did happen in Iraq. It is not an embarrassment to the country. This kind of thing can happen anywhere, and it has happened elsewhere. We try to cover that in the material that we publish. It's important for people to know about this, so they do work to separate these products. And again, we love to use technology. It's expensive. I think eventually we'll all be doing that. We'll be importing drugs from around the world into the United States, into other countries, from other countries. You know, we need a way to be able to identify these drugs through technological advancements like barcoding and like radio frequency identification of the doses. We need to help our brothers and sisters that are out there on the front lines as pharmacists, doctors, and nurses taking care of patients in hospitals and ambulatory centers and doctor offices and so on. It is horrible to be involved in a medication error where someone, especially where someone is hurt. We even refer to the health professionals as the second victim, after the first victim being the person that was hurt by the medication error. And I think we have made great improvements over the last 10 to 15 years. Around the world, we have seen improvements in labeling and packaging, but it's not over yet. We need to do more. And now we are facing massive vaccinations with the new coronavirus vaccines that we will see. There will be special storage conditions for some of them that if they're not followed, then we will not be able to adequately vaccinate a patient. There may be other problems with the labeling. We have not seen them yet. We hope those that are reviewing the labeling will take that into account. You can see how the labeling of vaccines can impact medication errors. So we don't know what's coming yet with the COVID-19 vaccines. There are several different types. They are being generated from different countries around the world. And we have yet to see any of the labeling or packaging. We hope none of them are Twocomponent. We have no word that they are, because that would even further increase the possibility of an error. I don't believe they are. We're trying to find out more information on each of these as they go through the testing processes. At any rate, we've enjoyed doing the presentation. It was an honor for us to be able to do this the first time. And so, again, let me thank the Upsilon Monitoring Center for allowing us to do this. And we hope that we can do it again in the future. And, you know, please take a look at the IMSN website, International Medication Safety website. Just type that into your search feature in your browser, and you will come across it. And we have, I think, about 25 different countries that are members, including regulatory authorities and PV Center, and Upsilon Monitoring Center is a member. Our FDA is a member. Health Canada is a member. EMA in Europe is a member. With that, I thank everybody for attending, and until next time, thank you very much.